Well, good afternoon. Thank you all for joining today. We apologize for being our presenters. I think the St. Patrick's Day leprechauns are playing tricks on our internet. So we've just been cutting in and out. So I do apologize if we cut out today. So we're going to try and hope that things go smoothly here on out. So we'll see what happens. So again, we appreciate everybody's time today. And your attendance as we discuss how the COVID-19 pandemic brought a multitude of new diagnosis and procedure codes with new coding guidelines, and how these new code sets brought a renewed emphasis on coding validation. Audrey, if you can go to the next slide. We do have some housekeeping we want to get through real quick before we get started. Make sure you ask your questions throughout the presentation. You can do this using the question feature in the dashboard. If you do want to follow along with the slides today, we do have those in the handout section of your dashboard as well that you can download. And if you experience any sound issues, which is a strong possibility today, check your sound settings. If you're not able to hear through your computer speakers, you can also join via the passcodes and phone numbers that are also located in the audio section of your dashboard. But regardless, we are going to be sending out a recording of today's presentation so you can listen in again. And lastly, we do value your feedback. So immediately following the webinar, a survey will launch. So we appreciate your feedback. If you can go to the next slide, Audrey. So today's presenters, we have 3M expert Sue Bealey, our clinical content development manager with our consulting services and outsourced services, and also Audrey Howard, senior inpatient consultants with compliance and audit services. We have a lot to get to today, so I am going to go ahead and turn things over to you, Sue. So let's get started.
Okay, good afternoon, everyone, and thanks for joining. I want to start today by saying that our presentation evolved against the backdrop of COVID-19. And I think we can all agree that COVID-19, the pandemic, has been, tragic and difficult all the way around. Speaking from a coding and CDI perspective, coding and CDI professionals may have experienced personal challenges throughout this pandemic with things such as childcare requirements, illness of themselves or their family, or a burnout, a multitude of things. They have maybe been moved to working remotely or moving from a hybrid situation to totally remote, along with the rest of their family, children, and other family members. Some or all of our nursing CDI staff may have been moved from their CDI jobs to frontline patient care positions, resulting in understaffed or unstaffed CDI departments. Surge of COVID-19 admissions may have led to caseloads greater than CDI professionals could see on a concurrent basis. The amount of clinical clarification and querying of COVID-19 cases may have increased, and obtaining query responses from physicians and other hard-pressed providers might have been really labor intensive as they were struggling to take care of patients. And speaking of the provider staff, we heard about hospitals placing physicians in areas of high need and areas where, they may not have, been familiar working in, such as ICUs, and hospitals brought in locum tenens physicians to help with surges. And all of these providers, working kind of out of their norm, may not have been necessarily aware of the documentation requirements that we need to support, good coding and tell that patient's story. And, it was just, literally hard to get documentation down when they were in the middle of a surge, just simply trying to survive taking care of patients. We also, had to deal with this barrage of new codes and coding guidelines that seemed to come at us every time, we turned around. and CDI and coding professionals, along with the rest of the medical community, had to learn about the COVID disease process and its manifestations as we were, as they were literally being discovered on the fly, as people learned more and more about how this disease was affecting the entire body system. So we all really, I think, tried to power through these challenges and hurdles because as coding and CDI professionals, we're really committed to obtaining thorough and accurate documentation and to tell the code and coding to tell the patient's story and to provide, much needed information about what happened to the COVID-19 patients. So next slide, please. Despite all of these hardships that I mentioned, and many more hardships and difficulties that we experienced, personal and professional, Audrey and I found that the COVID-19 event was such a professionally stimulating event from a coding and clinical documentation perspective. And why do I say this? Why do we think this? First, we knew, very early on that this pandemic was something very big, very serious, chaotic, deadly, disruptive. And so much was unknown about the disease and the course of treatment. We were learning something new daily about the disease process. We learned that loss of sense of taste and smell was pretty diagnostic of COVID-19, perhaps better than a lab test, if you will. And we, learned that the heart attacks and strokes patients were experiencing might actually be a result of clotting disorder brought on by COVID-19. So we had to learn to be suspect about everything that was happening to patients with regard to COVID-19 and potential manifestations. And as coding and clinical documentation professionals, we knew more than ever that our ability to produce a well-documented and coded record, coding symptoms if appropriate, and linking manifestations to COVID-19 was really of the utmost importance to support concurrent clinical research activities, provide information about this disease and potentially efficacious treatment in almost real time. And we wanted to be certain that we could leave a legacy of coded data for all those who would come, and study this disease and this pandemic for the next 100 years. So second, we found it to be so professionally stimulating because, we were showered with all these new codes and coding guidelines, like I mentioned earlier. And, this had never happened before. These were not our normal and planned and prepared for October 1st updates that we, could educate everyone and, be aware. We had to quickly incorporate new codes, new coding guidelines, change course, rethink how we had been coding, COVID-19 cases, and, incorporate these new guidelines, develop new queries, COVID queries for our physicians and providers. So, from that aspect, it was, professionally stimulating and challenging. Thirdly, as we began looking at COVID data to understand the impact of the disease and how it impacted severity and mortality or length of stay and outcomes, we were both really struck by opportunities that we saw hiding, and I say hiding in quotes, in this COVID-19 data, opportunities to improve coding and improve clinical documentation of COVID records. And this is what Audrey and I are going to focus on today for our presentation, the insights that we gleaned from this data. Moving on. The agenda, just wanted to, review that quickly. I already, just introduced our presentation. I want to spend the next few minutes talking generally about auditing, and then we'll move on to these hidden opportunities that we identified, lessons that we learned from our review of data and records, and then we'll wrap up and have some time for questions. So just to spend, a few minutes talking about auditing, why do we audit? Kind of going back to why do we do this auditing thing? So we audit to validate coding accuracy. We audit to ensure compliance with rules and guidelines and to detect and prevent fraud. We audit to ensure staff performance. We audit to ensure accurate reimbursement. There are many other reasons for auditing, but these are, probably the top, 5, 6 reasons that we perform audits. And when do we perform audits? We can perform them prospectively before a claim is submitted. We can perform them retrospectively after the claim is submitted. And how do we perform audits? We perform focused audits, reviewing cases with, for example, cases with 1 CC or 1 MCC, looking for opportunity. Or we'll audit 10 charts every month per coder, looking to validate their performance. Or we might look at 10 queries per CDI professional to ascertain that they were compliant or there were no misquery opportunities. And then we can perform random audits, maybe, reviewing every 10th record to see what we might find. But, I will wager that this is something that we typically don't do very often because, most departments don't have the bandwidth to, add that to their audit plan. So, I'll say, maybe a little boldly that, if we really look at it, auditing is often very prescriptive, and sometimes it seems a little humdrum. And I know that sounds, odd, but remember I said earlier that the pandemic, COVID-19, was professionally stimulating. Well, when we started wondering about how well this COVID patients' stories were going to be told and wondering, what that story was going to say about care that was delivered and patient outcomes and things like that. And we said, let's just take a look at COVID data and see what we might find. And we also audited COVID records, and we just kind of bucketed the opportunities that we saw sort of jumping off the page or jumping out at us that were kind of obvious, maybe not so obvious. And those buckets are present on admission opportunities, sequencing opportunities, coding opportunities, and documentation opportunities. So, that being said, I'm going to turn this presentation over to Audrey to talk about the first hidden opportunity. But, before she starts to do her presentation, we have a poll question for you. We're curious, with regard to auditing at your facility. Do you have a comprehensive audit plan? Do you audit the most, or do you audit the most important areas? Do you not have the bandwidth to perform audits, or do you use an outside company to perform your audit? So if you'll select one of those, Lisa's going to give us the results, and then Audrey will move on to her presentation. Thank you.
All right, thanks, Sue, and everybody. If you would like to put in your vote, go ahead, and I'm going to go ahead and close it. All right, so we have 43% said that they have a comprehensive audit plan. 19% said we audit the most important areas. 8% said we do not have the bandwidth, and 30% said we have an outside company that performs our audits.
Wow. Excuse me. This is Audrey. That is interesting with the percentages, how it played out there. So thank you for responding to the poll question. So then I'm going to take it over from here and kind of go into what we found almost immediately when we were looking at the COVID-19 data, as well as doing some record reviews. The first hidden opportunity was found to be related to present on admission indicators. Most of the cases reviewed had a present on admission indicator of Y for yes for COVID-19 diagnosis, which makes sense. However, there are several instances where we saw other POA indicators. The POA indicator seems to be a simple abstracting task. However, it can add to the story about the patient's hospital encounter, and we want to make sure that we are telling the correct story. Here are the POA indicators that are available: yes, no, unknown, and clinically undetermined. The next several slides, I'm going to discuss the indicators in more detail. As I stated earlier, the POA indicator of Y for yes is typically the most common POA indicator assigned. It means the diagnosis is present at the time the order for inpatient admission occurs. It includes any condition that develops during the outpatient encounter, such as emergency department, observation, and outpatient surgery prior to the inpatient admission. The POA indicator of N for no is assigned when the condition develops after the order to the inpatient admission. Using POA N is essentially saying the condition developed during the hospital encounter. Therefore, a POA flag of not present on admission for a COVID-19 diagnosis is telling the story that the patient contracted COVID-19 while a patient in the hospital. If this is the case, then it needs to be reported as such. However, if that is not the case, reporting it as such may have a negative impact on the facility. It is not always straightforward identifying when an infectious disease develops, and COVID-19 has its own obstacles as well, including incubation period, false negative lab results, and timing of lab results. A patient may be exposed to COVID-19 but not develop symptoms for several days, up to 2 weeks later. Even when the patient is tested, the results may return negative on the first test, but later on the next test returns positive. In both of these instances, the patient probably contracted the infection outside the hospital encounter. In addition, at the beginning of the pandemic, the lab results took a little bit longer than normal to return. These delayed results have been challenging to coding professionals. For COVID-19 or any other condition, if there is any question regarding if the condition was present on admission or not, the provider should be queried for clarification. And we'll talk more about this query in a few seconds. Although the POA indicator of U, which stands for unknown, is an available option, in my opinion, U stands for unacceptable. In my opinion, no diagnosis code should be billed with a POA indicator of U. The provider should be queried if the documentation is unclear, vague, or inconsistent. During our data analysis and record reviews, we did see a few cases where U was assigned for the COVID-19 diagnosis, and Sue and I believe that this is a good query opportunity. Provided here is an example of a potential query to clarify the COVID-19 diagnosis, the POA indicator status. We're basically asking, was it present at the time of the order to the inpatient admission? Was it not present? Or, dear provider, are you clinically unable to determine this? If the provider's documentation in the medical record or in response to a query indicates they cannot decide if the condition was present on admission or if it developed after admission, then it is acceptable to assign the POA indicator of W. POA of W is assigned on the provider based on the provider's clinical judgment. The coding professional cannot make the decision on their own, and the diagnosis that the diagnosis was clinically undetermined. So what is the takeaway from our discovery of POA indicators other than yes on COVID-19 records? The POA indicator is adding to the story of the patient's encounter, and Sue and I realized that POA indicator is critical to get right. We want to tell an accurate story. The importance of POA indicators goes beyond COVID-19. POA indicators are becoming a factor in an increasing number of quality metrics beyond the original use of hospital-acquired conditions. We have been doing some audits with patient safety indicators, or PSIs, and POAs are critical to those. For example, with sepsis, deep vein thrombosis, and pulmonary embolism, to name a few. But these are the conditions where we find the most opportunity for change. In addition, other quality metrics such as mortality measures and the Alex-Hauser comorbidity index are using POAs in their measurements. Sue and I realized that some coding professionals and CDI specialists are assigning the POA indicators to all the diagnoses after they coded the entire record, and we are struck by perhaps how autopilot the POA assignment has become. Coding professionals would click, 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 yes, all the way down the list. And our recommendation would be to assign the POA indicator at the time you assign the code. Changing this practice could help ensure the accuracy of the POA assignment and the inclusion or exclusion of the case in a quality metric. In addition, we also recommend running some reports on POA indicators with no or unknown as the indicator. Maybe you will see a trend by diagnosis, by coder, or even by service line. Investigating further, being curious about POA indicators other than yes, may identify additional areas for auditing. What jumps off the page at you when you're looking at these reports? The next hidden opportunity we identified when reviewing cases and analyzing data with COVID-19 diagnosis was with the sequencing. In the beginning of the pandemic, before the release of comprehensive guidelines, there was some confusion regarding what was to be sequenced as the principal diagnosis. Was COVID-19 always to be sequenced as principal diagnosis regardless of the other conditions the patient had? Ultimately, the guidelines for principal diagnosis in COVID-19 patients so sorry. Sorry about that. Ultimately, the guidelines for principal diagnosis in COVID-19 patients essentially follow the same sequencing guidelines for other conditions. Sequencing of the principal diagnosis depended on the circumstances of admission, is dependent upon the circumstances of admission and must be decided on a case-by-case basis. If COVID-19 meets the definition of principal diagnosis, then code U07.1 should be sequenced first, followed by the codes for the associated manifestations. If COVID-19 does not meet the definition of principal diagnosis, then it will not be sequenced as the principal diagnosis, even if it was present on admission. Sequencing is all about the definition of principal diagnosis. What was the condition after study which was chiefly responsible for necessitating the inpatient status? There are a few existing guidelines which provide sequencing direction, and that includes your sepsis, the obstetrics, and transplant complications. And those sequencing guidelines then must be followed. So let's go through a few examples of when COVID-19 could be sequenced as principal diagnosis or a secondary diagnosis. And sepsis is a good place to start. If a patient is admitted with pneumonia due to COVID-19 and the patient's condition progresses to viral sepsis, which is not present on admission for argument's sake in this scenario, the COVID-19 will be sequenced as the principal diagnosis, followed by the codes for the viral sepsis with a POA indicator of N for no, and then viral pneumonia. However, if a patient is admitted with sepsis and COVID-19 pneumonia and the sepsis meets the definition of principal diagnosis, then the code for viral sepsis should be assigned as principal diagnosis, followed by the codes for COVID-19 and viral pneumonia as secondary diagnoses. This is following the guidelines stating to sequence the systemic infection first, followed by the localized infection. Another example is related to fractures. A patient admitted through the emergency department after a motor vehicle accident with a fracture of the femur. In the ED, they test the patient for COVID-19 per protocol. The test returns positive. The patient is asymptomatic but put on isolation protocol. The patient goes to surgery for fracture repair. Now, in this simplistic scenario, the traumatic fracture, femur fracture, is sequenced as the principal diagnosis because that is the condition which necessitated the inpatient status. The patient would not have been admitted to the inpatient status at this time for the treatment of the COVID-19. So once again, you're always looking at what are the circumstances of admission, and it is on a case-by-case basis. So let's switch up this example a little bit. The patient is at home and has not been feeling well for the last few days. They've been coughing, feverish, short of breath. While at home, the patient in their weakened state falls, injuring their hip. So they go to the emergency department. And in the emergency department, they do test positive for COVID-19 and is requiring supplemental oxygen for acute respiratory failure. An X-ray is done, and that does confirm fracture of the hip. The patient is admitted to ICU due to COVID-19 pneumonia and acute respiratory failure and a fractured hip. The hip is stabilized, but they wait to do any definitive treatment until the infectious condition is under better control. Now, in this circumstance, based solely on this limited information that I just provided to you, the COVID-19 is sequenced as the principal diagnosis. It was the condition that required the inpatient status. Now, we can always muddy the waters and complicate the scenario a little bit more. I mean, what if the patient eventually goes to surgery for fracture repair? What if the patient eventually requires mechanical ventilation or a trach or an ECMO? These are some real scenarios that are taking place. That you always have to remember to go back and look, what was the condition or the conditions which required the inpatient status? And in addition to that, you have to apply all the applicable guidelines, such as 2 or more conditions meeting the definition of principal diagnosis. And then you need to select the most appropriate principal diagnosis based on that. In my opinion, the principal diagnosis selection is the most complex aspect of coding, but it is also the most important. It is the main character in the story that you're trying to tell. When COVID-19 was assigned on a case, either as a principal or a secondary diagnosis, Sue and I were looking at the top 15 DRGs to which it was associated. Not surprisingly, the most common DRGs were the complex pneumonia DRGs. That's 177 through 179, which is where the COVID-19, the U07.1 code is classified. And also the sepsis DRGs, which are DRGs 870 through 872. So that obviously made sense to us. However, we did see several instances where possible respiratory manifestations of COVID-19, such as respiratory failure or pneumothorax, and also non-respiratory manifestations, such as strokes, AMI, and acute kidney failure, were sequenced as principal diagnosis. The current guidelines state that when the reason for admission is a respiratory manifestation of COVID-19, you sequence U07.1 as the principal diagnosis, and you assign all the respiratory manifestations as an additional diagnosis. The guideline also states that when you're admitted for a non-respiratory manifestation of COVID-19, then you're still going to assign the U07.1, or your COVID-19 as the principal diagnosis, and then all the other non-respiratory manifestations as a secondary diagnosis. So knowing these guidelines, we recommend taking a look at those records where COVID-19 is listed as the secondary diagnosis, and the principal diagnosis may be a manifestation that's related to the COVID-19. We are not saying that the case is coded incorrectly, but a second look verifying the principal diagnosis accuracy would be beneficial. Our understanding of the COVID-19 disease process is growing every day. Where the literature first stated that the condition was a respiratory condition, it is now expanding, confirming that it affects many body systems, vascular, neuro, kidney, liver, GI, basically affecting patients from tongue to toes. We want to verify the documentation in the record is accurately classifying the patient's entire condition. Shifting gears a little bit. For HIV patients with COVID-19, the sequencing is going to depend upon the circumstances of admission. Patients with HIV are at an increased risk of becoming infected with COVID-19, but HIV does not cause COVID-19. In other words, COVID-19 is not an HIV-related illness. Therefore, it would be rare for HIV to be sequenced as the principal diagnosis in a patient that also has COVID. But just because it's rare doesn't mean it doesn't happen. It's always going to depend upon the circumstances of admission. What is your documentation saying? What is the provider including in this record? So this slide goes into some detail about the new coding guidelines related to multi-system inflammatory syndrome, or MIS, which became effective on January 1st of this year, so just a couple of months ago, when the new code for MIS became effective. It shows that the MIS diagnosis can be sequenced as a principal or a secondary diagnosis, and once again, depending upon the circumstances of admission. So the lessons that we learned from the review of the COVID-19 records and data analysis basically reinforced what we always knew. Stick to the basics. What were the circumstances of admission? What is the main character in your story? Although it may appear your story has complex twists and turns, you want to keep it simple and apply the principal diagnosis definition. If the condition does not meet this definition, it was not the intent of the admission, or it did not require inpatient status for care, then it can't be sequenced as the principal diagnosis, or it can't be your main character in your story. You can apply this type of thinking to other potential audits as well. Sue and I recommend running a report on your top volume DRGs. Are there any surprises in this list of DRGs? What did you see? More importantly, what did you not see? Is there anything you can review in these records that could impact change? You are not going to know what you find until you go and look. Okay, at this time, I'd like to turn it back over to Sue and discuss our next hidden opportunity.
Thank you, Audrey. I'm going to spend some time talking about coding-related hidden opportunities. So one of the first opportunities that we identified related to ARDS and acute respiratory failure. We reviewed COVID-19 records of patients admitted to the hospital with pneumonia and respiratory failure that progressed to ARDS. So there's an excludes one note under category J96 respiratory failure that directs one to assign code J80 for ARDS only, which means that if acute respiratory failure and ARDS are documented in a record, the code for ARDS is applied, not the code for acute respiratory failure. So we saw instances of a code from category J96 assigned with code J80. We also saw codes from category J96 assigned and no code for J80 assigned when both ARDS and acute respiratory failure were documented on the record. So we identified this as a hidden opportunity. We know it's not uncommon for coding professionals to overlook excludes notes or misinterpret them. And we realized from an audit perspective that this could be investigated by looking in data for instances when both codes were assigned to a record as well as pulling a sample of acute respiratory failure cases, perhaps records of patients who had been on a ventilator greater than 96 hours to see if code assignment for ARDS may have been missed. The next opportunity that we identified was, if you'll recall, prior to April 1st, when we first started into the pandemic, the code that we assigned for COVID-19 was B9729. But on April 1st, we got the new code, the U071, that was specifically associated with COVID-19. Automatically, it's a concern when you change kind of in midstream from one code to another. And when we looked at, aggregate coded data, we found the following scenarios. One, we found scenarios where B9729 was assigned for patients who were discharged April 1st and onward. So this would be incorrect, most likely, because April 1st discharges and on should be the U071. So there are a couple, possible reasons for this. There may be confusion. Well, the patient was admitted in February when we were using B9729, so we should use that code, which the code became effective for discharges or encounters of April 1st and beyond. So it doesn't matter when the disease process started, it's when did the encounter end in this instance from an inpatient perspective. We also found that code B9729 and code U07.1 were assigned, both codes were assigned for patients discharged April 1st and onward. So you might say, well, how could that happen? I thought that U07.1 became effective on April 1st. Doesn't the system, encoder, grouper kind of ferret that out? Well, B9729 is not used to code COVID-19 cases. However, it is still a valid code because it is a code for, generic coronavirus. And it is possible that patients can be admitted to the hospital with a generic coronavirus pneumonia or upper respiratory infection that's not COVID-19. So chances are it's incorrect, especially when it occurred over this time. But to be absolutely certain, you'd have to review the record. And then lastly, we saw code U07.1 assigned for patients who were discharged prior to April 1st. So we don't know how that happened because that code wasn't valid prior to April 1st. So not quite sure really how that happened. Something probably not right in people's systems perhaps. But again, that's something good to identify so it could be fixed. I call this particular opportunity low-hanging fruit. It's very easy to run a query to look at how, B97 and U07 were looked. It's a fairly quick audit, and it's a fairly easy fix as well, to get that corrected. The last coding opportunity has to do with viral sepsis and viral pneumonia. And when Audrey and I, talk to people about this particular topic, we usually preface the conversation by saying something like, well, I know this is kind of picky or, kind of coding nerdy picky, but so, in COVID data, we identified instances of pneumonia being coded to J12.9, which is the code for unspecified viral pneumonia. If the pneumonia is linked to COVID-19, the accurate code assignment should really be J1289, other specified viral pneumonia. So, maybe a little picky, but technically J12.9 is incorrect. To really validate that, you would have to review the record to see, whether there was a link between the pneumonia and the COVID-19. If there wasn't a link, then J12.9 would be correct. We would also suggest querying. And then I guess there's always the opportunity that the COVID-19 patient could have some other kind of viral pneumonia, but probably not likely, but possible. Also, I wanted to note that January 1st, 2020, when we got a new slew of ICD-10 codes relating to COVID-19, we got the code J12.82, which is a code that is specifically for COVID pneumonia. So at January 1st and beyond, it would be good to take a look and see, how that code was being used. When we looked at some recent data, we saw instances of J1289 or J12.9 unspecified viral or other specified viral pneumonia being reported along with J1282, the COVID-19 pneumonia. So those are cases that should be reviewed. It's possible that they could have an other specified viral pneumonia or an unspecified viral pneumonia with COVID-19 pneumonia, but probably not likely. So, that is something that should be reviewed. In the same vein, when we talk about viral sepsis, we have sort of the same situation. We have code A4189, which is other viral sepsis, which if the sepsis is linked to the COVID-19, A4189 would be assigned. But we saw instances of A41.9, unspecified viral sepsis being assigned. It is possible that the patient might have another kind of viral sepsis, but not likely again. So those are areas that can be reviewed. And maybe those don't make a lot of difference, but from a coding perspective, they're potentially incorrect. So, the pneumonia and the sepsis, again, I call that low-hanging fruit. Easy to run a query, look and see if you have issues with this, and fairly quick audit to do, and make correction. So what lessons did we learn regarding this? First, it's very important to verify accurate code assignment, verify that accurate code assignment is based on the effective date, and anticipate that when changes happen, be it our typical October 1st updates or what we experience throughout this public health emergency, that there's pain points when code changes are made, either a change, a deletion, an addition, and that is a prime area to go and look and see how everyone is performing regarding that. Second, really, you've got to investigate when things don't add up. And third, we say proceed cautiously, carefully, and curiously. When we talked about the J1289 versus the J12.9, caution, probably it's wrong, but we want to be cautious and go look at the record. Is it possible that there was no linkage between COVID-19 and the pneumonia? Who knows? So, take all of that and heed. And you have to read and ask questions and verify coding conventions and guidelines, as you move forward. The next hidden opportunity that we have is related to clinical documentation. So let's look at some hidden opportunities. First, on the left there, we have the diagnosis of acute injury. When we looked at data, we saw this diagnosis coded along with a procedure code for the initiation of hemodialysis. And when we reviewed the records, we saw scenarios similar to the following. COVID-19 patient who experienced a significant bump in their creatinine, and that bump in the creatinine did not recover well or perhaps at all. And we asked ourselves, does the diagnosis of acute kidney injury reflect how sick this patient is? How the COVID has impacted their kidneys? Does it represent the clinical presentation and the treatment rendered? And these scenarios, we felt, presented an opportunity to query for specificity. Is there something more specific than acute kidney injury, such as acute tubular necrosis. So, we could really get at the specific diagnosis for the patient and to show the impact of the disease. Second, when we looked at aggregate coded data, we were struck by the number of COVID cases with a secondary diagnosis of diarrhea. So what we did is we looked at the top secondary diagnoses in a COVID population. And I think when we look at records individually, we look at what's been coded and we see a code secondary diagnosis of diarrhea, you kind of go, you just gloss over it perhaps. But when you look at it in aggregate and you go, wow, there's like 63 cases of diarrhea as a secondary diagnosis in the COVID-19 patient, So, as we learned, over time that the just tremendous impact that COVID-19 had on organs in the body and body systems, it was recognized that COVID attacks the lining of the intestines and thus the symptom of diarrhea. And that symptom of diarrhea presents an opportunity to work with providers to determine if the diarrhea was just a symptom or is it a manifestation of COVID. And if documented as such, if COVID and diarrhea are linked, you can more accurately classify this as a viral diarrhea or viral enteritis. And the code is A08 something, I believe. I can't recall it offhand. So when you think about when you walk into an office building, like a medical building for a doctor's appointment, or walk into the hospital, what are they doing? They're taking your temperature and they're asking you screening questions. And we see those screening questions posted everywhere, even in stores and restaurants. Do you have fever, shortness of breath, cough, diarrhea, right? Diarrhea, they ask about diarrhea all the time. So it's, not a pretty subject, but, when we looked at data in the aggregate, we were just really struck by that. So, a hidden opportunity. And then lastly, I've already talked about ARDS and acute respiratory failure, but I want to approach it from a slightly different angle. One of the things that struck Audrey and I when we looked at aggregate data, those top secondary diagnoses in the COVID population, we were struck by the fact that we weren't seeing ARDS coded. And, our first hypothesis was the one I already explained. Was it a coding thing? Did the coding professional not see the excludes one note and just assign acute respiratory failure when ARDS should be documented? But we kind of vetted that out, and yes, that did happen to some extent. However, it still didn't add up. So we started talking with CDI and coding professionals and asking what is the documentation pattern at your facility regarding ARDS. And some of the responses we got were, one, we don't know why our doctors don't document ARDS. Or two, we don't query for ARDS. Or three, our doctors were just surviving, to take care of these patients in these horrible surge conditions. So, we encouraged CDI and coding professionals to talk with their pulmonologists or their intensivists about this. Everything that we have heard about and read is, a lot of terrible things happen to the patients, but one of the really serious ones is the impact on the lungs, and ARDS destroys the lung tissue, perhaps leading to the patient being oxygen dependent for the rest of their life. I just read an article that there have been 12 double lung transplants in the country to date for COVID destruction of lung tissue. So we really want to capture this information so clinicians who are learning as they go with this disease, can do research and determine, what might help, and we've heard so much about, moving to proning the patients to provide expanded lung capacity, maybe not intubating as quickly, because patients may do better if we don't intubate and ventilate as quickly. So, you know, I think super important to get it right from a diagnosis perspective. So how would you delve into doing research on this hidden opportunity? You know, we would recommend, you know, again, looking at cases of acute respiratory failure on a ventilator greater than 96 hours, you know, because the likelihood of that patient having serious respiratory problems that could include ARDS is high. And, you know, look at things like, is the patient on a proning protocol? Did their chest x-ray reveal bilateral pulmonary opacities? Did they have a decreased PF ratio? And you might want to, you know, also note that there are a lot of other signs and symptoms, you know, that are used in diagnostics used in making a diagnosis of ARDS. But those are some of the things you might look at, and then sit down with the clinicians to determine, you know, what was going on with the patient. Do we have the most accurate diagnosis to help, you know, get a plan in place at your organization for querying physicians to try to get it right while care is being delivered? So what lessons did we learn from these hidden opportunities? We learned that it's really important to dialogue with physicians and providers, especially about the unknown, like this unknown COVID territory we've been, you know, knee deep in this past year. Secondly, understanding of the disease process helps provide focus and where to look for opportunities. So, you know I've said this already, and Audrey said it, you know, with this COVID pandemic, I have read clinically more about a disease process than anything else in my professional coding and CDI career. And, you know, sometimes that's really necessary, you know, to ensure that we are doing the best job collecting what we can for these patients. And then specificity makes a difference. You know, it provides a more accurate and thorough patient story. It impacts severity and mortality in disease, potentially your reimbursement, and it supports clinical care, treatment, and research efforts. So I'm going to turn this back over to Audrey to, you know, offer some of the conclusions we arrived at.
Yes, thank you, Sue. And so what conclusions can we draw from, you know, all the data and the research and everything that we've seen and read about COVID? Well, first, it is essential to review aggregate data, investigate and audit when new or out of the normal events occurred, such as COVID-19, because opportunities about these situations may arise, as we have discussed today. Second, auditors must possess or obtain an understanding of the subject. I know we speak for many of you when we say that we read and read and read, is discussed with, and as well as discussed with our physicians and clinicians about COVID-19. Information is knowledge. Knowledge is power. It's good to have this information so that you can apply it to your day-to-day functions. Also, it is important to review outside of your normal audit parameters. And what we mean by this is looking at the top 15 DRGs or the top 15 principal diagnoses or secondary diagnoses that may be associated with when we are looking at COVID-19, but also expand that out to other situations as well. Looking at the top 15 secondary diagnoses in the COVID situation, we identified, you know, the symptom code of diarrhea that that Sue had already discussed, and then also the absence of ARDS. So it's not only what do you see, but it's what you don't see in there. What you may think that you would see something, and if it's not there, well, why is it not there? So being investigative and asking these questions and wondering why, you know, being curious about this is also very important. And then lastly, it's always good to have a fresh set of eyes review your data and audit your records as they see things that may not be, that you may not due to your familiarity with your facility. So at this, Lisa, I'm going to turn it over to you. Before we open it up for questions, Lisa, I'll let you discuss these slides.
Sure, no, and the information is just incredible that you both went to or went through. So we certainly appreciate all the time and effort that you put into this presentation, because there is just so much knowledge, and like you said, there's just constant changes that we need to keep up on. So what I'm going to do, because we are right about at time, we do have several questions that have come in that I'm pretty sure we want to make sure we expand on. So why don't we do this? I'm going to make sure I get the questions over to both you and Sue to complete, and then we'll send them out within the archive, just so you can kind of take your time in answering them, because I just don't want us to have to rush through it given on time. But what I do want to do is go over a couple opportunities for education for everybody. We do have our coding and compliance services. So as they said, the second pair of eyes, we do offer those services if you are interested in them. And then we also do have coming up excuse me, an educational boot camps. So again, if you're interested in more education opportunities and getting more information, I'm going to launch again this last poll. And really, this is just for you to let us know if you're interested in learning more information that we can send to you between, again, compliance and auditing services, that education boot camp, quality services, advanced CDI services, and performance advisory. So let us know if you are interested in actually a rep reaching out to you directly to learn more about our products and solutions. There is that opportunity to let us know in the survey. So once the survey launches, again, we would really appreciate your feedback. And if you'd like to learn more, let us know. We will be sending out the archive of the recording and presentation along with the follow-up questions here in the next couple weeks. And also we'll give you the opportunity to register for our next quality webinar, which will not be until May. So again, we apologize for starting a little bit late today. I'm so glad our internet held up for the past hour. So Sue and Audrey, again, we certainly appreciate your time today, as well as everybody else for joining us. And we look forward to next time.
Thank you.
Thank you all.
Bye-bye.